and we will get started. All right, so I've been treating thyroid and allergy in my ENT practice for about 20 years, which is about as long as I have known about this treatment, and started actually using it on myself and seeking to understand more about why this phenomenon occurs and why it works, to add T3 to the treatment regimen. So when I retired from ENT, I switched over to now exclusively treating people who need help with their thyroid, adrenal, sex hormones, and other endocrine problems who don't really get relief with the standard thyroid hormone treatments. And I'm just going to review a little bit from the first night, just in case somebody misses that. But levothyroxine is at least the third most, maybe the second most often filled prescription in the US. It was written 89 million plus times in 2021, and an estimated 23 million Americans are hypothyroid, according to one statistic that I saw. And that's depending on who you read, because even this statistic is controversial, because there was one recent study I saw that showed that there's a seasonal variation in TSH as a cause of subclinical hypothyroidism, since the definition of subclinical hypothyroidism is a TSH between 4 and 4.5 or so and 10 with a normal T4. This one study postulated that as many as 90% of the patients who are being given levothyroxine shouldn't even be taking thyroid replacement, and that what they have is actually seasonal affective disorder, since there's seasonal variations in TSH, apparently. I personally think that seasonal affective disorder is strongly associated with vitamin D3 levels, and I actually wonder if low D3 could be another reason for declining thyroid function over those later winter months in those people. This same study suggests that levothyroxine has no benefit in any patient who has a TSH value that's lower than 7. I tend to agree with them, but not for the reason that they postulate. Because in subclinical hypothyroidism, the problem is usually not insufficient T4. So many people who are treated with levothyroxine alone are not fully restored to normal and are often quite dissatisfied with their results. Remember, T3 is the active form of the thyroid hormone that stimulates your metabolism, your tissue growth, your brain function, etc., as we discussed last time. And most of the T3 that the body needs to function actually needs to be converted from T4 to T3 in the body tissues, which is basically all of them. And a significant proportion of patients with hypothyroid symptoms actually have problems not producing enough T4, but converting T4 to T3. And their disease is less about dysfunctional production of thyroid hormone and more about dysfunctional conversion of thyroid hormone. And so today, those are the patients I want to discuss, those who have symptoms and are put on levothyroxine and told that everything looks good, but still feel terrible. So also last session, we went over these 3 patterns of thyroid results that you can see in symptomatic patients when you start checking T3 and reverse T3. The first pattern is the regular type of hypothyroid patient, where the TSH is elevated, the T4 is low, and the T3 will also be low in these folks. And this is kind of end stage hypothyroidism. It's what happens in Hashimoto's disease once the gland is more or less totally replaced by scar tissue. This is also how patients who have had I-131 or thyroidectomy or other thyroid damaging treatments, such as chemotherapy or external beam radiation therapy, present. These other 2 ways of looking at thyroid labs are our focus for today, which are either low T3 with normal or mildly elevated TSH without low T4, and that's your subclinical hypothyroidism. And then this third type is elevated reverse T3 with or without, frankly, low T3. A lot of them will have low-ish T3 and with normal TSH. And I call these patients euthyroid 6 syndrome because it's actually in the ICD-10, and it's a really, really good approximation for what's going on with them, even though they are out walking around and not in the ICU, where you usually see the diagnosis of euthyroid 6 syndrome. There are a couple of other problems with following free T4 on immunoassay, because not only are there problems with the TSH not being an accurate way to determine the thyroid signaling status, as we just talked about in part 1, but there's also inaccuracy problems with the commonly used free T4 immunoassay. So in symptomatic people with a normal T4, it's generally suggested to repeat that hormone test with the gas chromatography mass spec, which more accurately shows that the immunoassay test can be falsely too elevated by sometimes as much as 30%. And a lot of times that is because of either biotin or because of ASO, high ASO titers, which can interfere with an immunoassay. Then this final one, of course, the normal free T3, normal free T4, normal TSH, and then the reverse T3 would be elevated, which, as we discussed last week, causes a functional and actual inadequacy of T3 signaling action in the body. So let's start with a case. So this lady is 31 years old. She was diagnosed with Hashimoto's disease back when she was 17. So the books and the NIH will tell you that Hashimoto's disease is a disease of middle age. I feel like that's not actually true. It may finally become symptomatic at middle age or be detectable with the TSH test at middle age, but it actually occurs very frequently quite early. So this patient came in, she was 31, and she was symptomatic on Synthroid, taking 112 micrograms every morning, which is a pretty substantial dose. She had, despite the Synthroid, 3 confirmed and possibly a 4th first trimester miscarriage in the past 2 years. Her symptoms were she felt cold, her hands and feet were cold, she was tired even when she first woke up in the morning, she had GI problems, constipation, gas, bloating, reduced libido, and dry skin. She also had some issues that suggested to us that she might have some adrenal insufficiency because she had orthostatic lightheadedness and salt craving. Her diet was gluten-free because her dad had celiac and because she had heard somewhere that Hashimoto's ought to be gluten-free. And her BMI was 19.6, so not overweight. So you don't have, I mean, that's a big deal, is you don't have to be overweight to be hypothyroid. So before I even drew her labs, I asked her to do 2 things. First, I asked her to start taking an adrenal glandular supplement that is made out of neonatal bovine adrenal glands to mitigate those adrenal symptoms and give her a very slight boost in her energy. The second thing I asked her to do is divide her 112 microgram T4 dose in half and take half in the morning and half at 12 hours later. So the reason I asked her to do that is to blunt those highs and lows that you get from only taking it once every 24 hours. because the variation can be 30% or more over the course of a day. And these highs are one of the reasons that Hashimoto's patients get such elevated reverse T3 as the body ramps up the deiodinase 3 to blunt the production of T3 to guard against thyrotoxicosis, which is actually not that uncommon in Hashimoto's. And sometimes, occasionally, that's all you have to do to get people started feeling better. The other reason is because I really want to get an accurate mid-dose reading. So most endocrinologists want to get a trough reading. So they take the meds in the morning, they have you come in before you take the next morning's dose and have your lab draw fairly early in the morning. This unfortunately completely misses these high peak levels and overdosing that can occur in the first few hours after once a day dosing. So then we wait a couple of weeks before we test so we can get this stabilized mid-dose reading on her levels. And I have her go to the lab and get the blood draw exactly 6 hours after that morning dose. And of these tests, the only one that's not in the reference range is the reverse T3. And you can see that this is remarkably high. I think anybody over about 13 is high, and hers was 3 times that. So one of the things that I do with this, and I'm just going to read these out loud in case anybody's listening with the video turned off. So her TSH was 0.66. Her free T4 was 1.66. So that's pretty close to the upper end of the normal range. Her free T3 was 2.9. As I mentioned last week, the normal reference range goes from 2.0 to about 4. 2.9 is below 3.0. I like to see 3.3 at a low end. 3.9 or so is the high end of my ideal. Her total T3 was 87, reverse T3 36.1. And what I do is I take those last two numbers and I divide the 87 by the 36.1 to get a ratio. And that ratio, total T3 to reverse T3 in her was 2.4, where the desirable range for that ratio is 12 plus or minus 2. So between 10 and 14. So these ideal numbers are for somebody who's on thyroid treatment. And remember, these reference ranges are, the reference ranges for these numbers are really, really broad, and my ideal ranges are pretty narrow. So depending on the circumstances, T4, which is the storage form of thyroid hormone, gets made into either T3 or reverse T3. Those are the only two pathways that it can take before it's either used or broken down further. And the only way you get high reverse T3 is by making it from T4. So her T4 being at the upper end of the reference range is clearly not helping her, as way, way too much of it is getting turned into reverse T3. So the ideal for the free T4 tends to be way down at the low end of the reference range. Particularly, this is if somebody is taking a medication that contains T4, I want her to take enough that her levels get up to 0.8, 0.9, but not really higher than that. So hers were way, way too high. Her T3, once again, the treatment goal is in the middle of the reference range, and I like 3.3 to 3.8. Hers was 2.9, and obviously she was symptomatic. So this gives us a lot of room to take this number upwards to get her feeling better and still be well within the normal range. So once again, the reason to test total T3 is this. We need it to compare apples to apples to the reverse T3 because both of these are free and bound numbers. So it's a total, it should be called total reverse T3. On its own, I don't really look at the total T3, but I'll tell you what, when I see one that's below 100, I already know that my ratio is going to be off. Pretty much always know that ratio is going to be off. So the reason we can't use thyroid binding globulin to calculate the free T3 to reverse T3 is because thyroid hormones are not just bound to thyroid binding globulin. And in our modern lab, we can just order a free hormone or a total hormone for T4 and for T3. Because of the amounts of proteins vary so much from person to person and from week to week, because of their relative estrogen status is one thing that affects it. So these total numbers really have a very broad normal range, and they aren't that handy on their own. However, the reverse T3 test really does show us that this lady is really, really making a lot of reverse T3 and really, really blocking a lot of the T3 that she has. So the range of ideal when you compare this as a ratio is not only steady, but it's pretty tight. I mean, between 10 and 14, that's a variation of about 30% at the very most. And you're not going to find this ratio in textbooks. There are a few research papers where you find the researchers using this, but it has not reached the textbooks yet. And I don't know when that's actually going to happen. So if you see a functional medicine doctor comparing your free T3 with your reverse T3, I really don't agree that there's much of any accuracy in doing so. Like I said, you could do a calculation if you knew the albumin, knew the thyroid binding globulin, but it would still only be an estimate. Because the free T3 or the T3 and the reverse T3 bind at the exact same rate to the exact same proteins and receptors, it's an apples to apples comparison. So when you check TSH in somebody who's not taking thyroid medicine, it does seem okay for the number to be as high as 2 or maybe even 2.5, as long as everything else looks fine and they feel fine. But once they're on treatment, it actually doesn't matter that much if a patient has somewhat low TSH, as long as their free hormone levels are in that ideal range. Strangely, I see people with TSH in the 3+ range all the time who are also taking statins for their elevated cholesterol, when the cause of their high cholesterol is likely their inadequate thyroid function. And it's interesting, I mentioned that to my cardiologist and he was like, oh yes, I absolutely agree with you. So I thought that was very interesting. And once again, I'll just mention, I don't measure the T3 resin uptake, the free thyroxine index, or the total T4. These are not needed. This patient had previously been found to have Hashimoto's disease, so I did not repeat her antibodies. But if she had not previously had those done, I would test the thyroid peroxidase antibody, the thyroid globulin antibody, and then in somebody with a lowish TSH like this, I would also check the thyroid stimulating immunoglobulin and the TSH receptor antibody, if the TSH is low and the patient had symptoms and hadn't been testing before. And because hypothyroidism typically existing in hormonal isolation, there's a whole other panel of labs I'm going to test on this lady. For example, I'm going to check a morning fasting ACTH and cortisol, for example, and I'm going to do that at a separate lab draw from the noon thyroid dosing. So this patient is taking a lot of T4 and she's not making it into T3. It is suppressing her TSH though, so she's been told she's fine, though clearly she was not, based on her symptoms. and her high reverse T3. So the next step was that she agreed that we would replace some of her T4 with T3. And I generally use the semi-equivalency, which is 25 micrograms of T4 is the same as 5 micrograms of T3. So a 5-to-1 ratio. A few studies have used 3-to-1. So I'm not doing exactly that here, but that's generally kind of the rule of thumb. So when I switch her over, I do it in 1 week steps. I try not to switch people faster because when their T3 has been really low and their receptors have been blocked, they have a lot of receptors. So when you suddenly have them have a lot more T3, all of a sudden, they're going to get overstimulated and they're going to have symptoms from that. And the symptoms I listed in part 1, so I'm not going to go over those again. So first, I am dividing the synthroid, as I mentioned. She's already at 56 plus 56, which is our 112 that she started with. And I'm going to give her a prescription for 25 microgram tablets of levothyroxine. And she'll take 2 of those in the morning and 2 of those in the evening. So 25 microgram tablets. I'm also giving her Cytomel or liothyronine 5 microgram tablets. And I'm starting very slow and very small. So a 2.5 microgram, which is half of a 5 of T3. And she'll do that for the entire first week. Then we will decrease very slightly again. So I'll go from 2.5 to 5. I'll drop the T4 by breaking one of the synthroid pills in half and having her take 1.5, and so on until she is up to 25 plus 12.5, so 37 mics of levothyroxine and 20 mics of liothyronine. And I might actually stop here. I might actually stop after she has been on the 7.5 plus 7.5, so 15 micrograms total of T3. I typically will stop and give them a couple of weeks on that dose and see how they feel, because the reverse T3 will continue to drift down after you change the T4 lower. And so a lot of times I will stop here, wait about 2 weeks, and then retest. And generally, timing-wise, what I have developed for people, and this seems kind of weird, and the patients fight it, but is I have them take both of the morning doses at the same time when they first get up in the morning. I am not nearly as strict as the pharmacies are about, oh, well, you have to take your meds and then you have to wait an hour after you take them to have anything by mouth. I think probably 30 minutes is plenty. And the only food that, there's 2 foods that really seem to interfere. One of them is soy, that impairs the absorption of T3. And the other thing is grapefruit juice. So I try to get people not to do grapefruit or soy close proximity to their thyroid medicine. But I would say 30 minutes before or after is probably sufficient for most people. Now, I don't have them do that right when they get started. But once they're kind of well established, then I let them be a lot more relaxed with when they're taking their doses. And if it turns out, oh my gosh, I forgot to take this and I already ate, I always tell them, just take it anyway. Just take it right now and continue and move on. So this waiting 2 hours to eat after you've taken your thyroid medicine, or waiting, not taking your thyroid medicine within 2 hours of when you've had a meal. It's just too excessive and it's too hard for the patients. Now, because liothyronine gives people so much energy, a lot of times what I will do is I'll ask the patient, okay, what time of the day, because they'll feel good in the morning when they start doing this. What time of the day do you start to wear out? What time of the day do you start to be feeling really, really tired? And a lot of them will say, oh, well, about 3 o'clock, about 4 o'clock. And so I'll say, okay, about an hour to an hour and a half before then, that's when I want you to take the second dose of liothyronine, not the Synthroid, just the liothyronine. So maybe 2:30 in the afternoon. And then take the second dose of the Synthroid right at bedtime. If you take the Synthroid too close to dinner, you've got a couple of problems. Is that if they're making any of it into T3, then it'll have them hyped up and energetic at bedtime. And so it's better to pop the pill in your mouth and then fall asleep. Dosing wise, liothyronine doesn't come in very many sizes. It comes in 5 micrograms and it comes in 25 micrograms. And I have never seen anybody who needed more than 30 micrograms. And most people are between 15 and 20 micrograms. So not only are you breaking the Synthroid, which is scored, but you're having to break the liothyronine. And they are generally not scored, and they are very tiny little pills. So you're going to have your patient get a good pill cutter. And the other thing is when the patient is titrating up in this way, they are instructed to get in touch with any adverse effect and then go back down to the previous dose where they were actually feeling better for a couple of weeks before they try it again. And typically what I'll do is I'll have them go back down and then wait 2 weeks and then test just to see where we're at. Because sometimes the escalation needs to even be slower than what I've showed you here. So you go to 2.5 and nothing, and then 2.5 and 2.5, and then 5 and 2.5, and then 5 and 5, and so on. And if the dosing is uneven, I generally will have them take the larger dose in the morning. And frequently some education would be needed if they are having adverse reactions with the T3 dosing. So after 2 weeks on T4, 25 plus 12.5, and T3, 10 plus 10, this patient felt much better. She had had a regular period, which was a big change for her. And I sent her back to the lab to do her 6-hour after morning dose. And her TSH had gone down a little. Her free T4 had gone down a lot. We need to talk about this. Her free T3 was at 4.2. This is maybe a little bit too high. And the total T3, 152, and the T3 of 10.3. So her ratio had bumped past my ideal range up to 14.8, where it had been 2.4. But here's the thing. If you get somebody's free T4 down this low, they are going to have problems with too little T4 as well, because T4, while it is a prohormone, is not totally biologically inactive. And patients who get down low will have a couple of problems. And one of them is that they will lose hair, like lots of it and drastically. And so it's clear that I overshot with this lady. And so I got her on too much free T3, not enough free T4. But before we move on, I want to just comment on this kind of patient, because menstrual cycles can be very irregular or even absent in these patients with the very high reverse T3. And they will have difficulty with conception, or they will have first trimester miscarriages as really, really common causes of infertility. And when you fix this, they will notice in general their irregular periods becoming regular. Their energy will increase, their sleep will become easier, more regular, their extreme cold will start to subside, they will get new hair growth But some patients will have basically telogen effluvium. They will lose a massive amount of their older hair as they start to grow their new hair. All right, so here's where we were with this lady. And the ratio, as you can see, is much better, even though it's a little bit high. The T3 is, like I'm going to say, just a little bit higher than where we want it. And interestingly, it turned out that this lady had gotten pregnant in the few weeks between starting and when she came back. So during pregnancy, the thyroid binding globulin and the sex hormone binding globulins go way, way up, and it drops the free hormone levels by as much as a third, which she was still very early days. So this necessitated increasing the T4 replacement until after delivery, when the sex hormone binding globulin comes back down. So most patients are not going to get pregnant in the first 4 to 6 weeks of doing this, but it has happened to me more than once in my practice that previously infertile women are able to conceive and carry to term. More commonly, they will notice irregular periods becoming regular first, but it is crucial to inquire about their desire to become pregnant, because many of these folks will have gotten complacent and will need to be reminded about alternative forms of birth control, because accidents make people. Now, this lady was very, very happy to be pregnant. She had been trying for years and had been told she would never be able to have a baby. So it was really a wonderful thing for her. But her need for T4 turned out to be double what I had been giving her. So we tested very frequently until we got this where we wanted it. And her T3 ended up staying the same. She delivered at full term. And her ultimate dose after she had delivered ended up being T4 of 25 plus 25, and her T3 at 12.5 plus 10. And she continued to feel well, and she now has 2 healthy children. So in her case, I really can't say that she had subclinical hypothyroidism for sure, because I didn't see her before she was being treated with the levothyroxine. But this scenario really seems to happen very, very frequently with subclinical hypothyroidism. So the definition, as I mentioned earlier, the subclinical hypothyroidism is TSH below 10 and above the quote unquote normal 4.5 and normal free T4. This is up to 10% of the adults in the US. My definition is a TSH above 2.5. If they're clearly symptomatic and have an abnormal T3 RT3 ratio or free T3 below 3.0. And when I was looking this up, there was at least one CDC study that showed that 15% of Americans have some degree of autoimmune thyroiditis, and their hormone levels fluctuate from total normal when they're early in the disease to frank hypothyroidism in about 50%, and total thyroid failure in some. And at some point in there, they exist within this definition of subclinical, maybe for many years if their disease goes quiescent, or if we cause it by accidentally taking out their non-cancerous thyroid nodules. And if they don't achieve remission by anti-inflammatory measures and changing their diet and things, their fluctuating hormone levels will continue to cause progressive damage to the thyroid gland. So Hashimoto's is by far the most common reason for hypothyroidism in general, but also for subclinical hypothyroidism. I mentioned last time that there are polymorphisms that have now been identified that decrease your ability to produce T3, particularly in the presence of levothyroxine. And these are not rare. It is one CDC paper that I saw said up to 32% More of the papers say more like 16% of people of British descent. But this is not an uncommon genetic variation. There are several other causes. These two heart medicines are both notorious for causing elevations in deiodinase type 3, which makes reverse T3. Checkpoint inhibitors, which are fancy new cancer drugs, steroids, epinephrine, iron deficiency, and stress. And stress comes in a lot of varieties. And it doesn't have to be abuse. It doesn't have to be physical, physical damage to your body or illness. It can be over-exercising in the wrong way. It can be an overly calorie restricted diet. One of the things that I did not mention is the very, very strong association of these subclinical hypothyroid people with insulin resistance. And insulin resistance is, of course, the primary driver of obesity and prediabetes and type 2 diabetes. So many of these patients are also overweight and fighting overweight with calorie restriction. Psychological stress is perceived by your body as just as harmful or just as deadly as physical stress. So high cortisol levels will do this. They push down on deiodinase type 2. They push up on deiodinase type 3 because your body is trying to conserve energy. So very, very interesting that can be the case. And also the very fact that the ACTH level is high suppresses TSH even in the face of low hormone levels, particularly T3, but also T4. I showed this slide the other day, and the reason I wanted to mention this again is just because in addition to pushing down on TSH and the production of the thyroid hormones, the elevated cortisol is actually one of the big reasons for the downregulation of deiodinase type 2, which in the periphery will lead to lower T3 levels, and the increased function of reverse T3, which leads to elevated levels of reverse T3 in the system. So even without the gene abnormality, or even without damage to your thyroid, subclinical hypothyroidism can be induced in the body by various forms of stress, metabolic disease, medications that we give our patients. So many of these patients with elevated TSH are asymptomatic, or the symptoms are subtle enough to go unrecognized, but they also have deficits. They have increased risks of congestive heart failure. They have increased risks of fatal and non-fatal coronary artery disease events and fatal strokes. They have elevated serum cholesterol and the not good small LDL. They have depression. They have decreased attention span and other executive function deficits. And sometimes, occasionally, I have seen this as the only problem. So a patient will come in to the ENT clinic. They're there for their allergies, but I feel a thyroid nodule. And I try to get them to take a supplement or try to get them to do this or that, and they can't remember it. And I've seen patients where I literally thought they were early onset dementia because their executive function and their attention span and their memory was so bad. And so I would ask them, please bring a family member in to help them get started. And when their T3 was corrected and the reverse T3 was down, they would wake up and go, oh my gosh, how was I existing before? I can remember things again. This is amazing. The other thing is that the mortality rate, the overall mortality rate, even in patients who are relatively asymptomatic with subclinical hypothyroidism, is significantly increased. And if you have them fill out a very detailed questionnaire, a lot of times they will have symptoms that they didn't recognize, even with T3 that falls within the reference range, which is admittedly very broad. So why is this? Well, so rat studies of combination therapy, T4 and T3 versus T4 monotherapy, shows that markers of euthyroidism, such as normal serum cholesterol levels, mitochondrial content of cells, enzymatic activity within liver and skeletal muscle, better approximated the values in the control rats when sustained delivery of T3 and T4 were used. So likewise, the pattern of T3 responsive genes in their brains was more similar to that of controls when the combination therapy was employed. And when they do crossover studies in humans, they will also have 10% lower free T3 levels than the comparable controls if they're only given T4, with similar TSH levels, and actually below normal in about 15%. And this was especially true if they could prove that the person had the THR92 ALA deiodinase 2 SNP. So the bottom line here is that measuring TSH in someone who's already taking levothyroxine or any kind of T4 does not tell you anything about how much T3 that person has. They frequently feel worse on T4 than they did on no treatment. And the higher the dose, the worse the problem gets. And they have those poor outcomes when treated with levothyroxine for the reasons that we discussed in part 1. And if you didn't get a chance to listen, this info is really key. I'm going to recommend that you go back to the part 1 replay and listen to that again. But in summary, it's failure to achieve normal serum or tissue T3 levels outside the hypothalamus, and the thyroxine that they have been given is more strongly converting to the reverse T3, which further blocks the action of the T3 that they do have. And our case study patient had both of those problems. So it's no wonder when T4 is the only acceptable treatment option for subclinical hypothyroidism that specialists might recommend that you give nothing and just wait and see, because it doesn't work for so many of these people. So what do we do with these folks who are on T4 and they're not feeling well? So these patients are angry. The non-physician healthcare providers are taking advantage of them, giving them all these supplements and all this bogus stuff that doesn't actually fix their problems. Because a lot of them actually do need thyroid hormone supplementation. So, you know, there is a subset of them, if you can get them on the right diet, if you can get their stress managed, they will feel better. But a lot of them will kind of get stuck in this spiral where they're too tired to cook healthy meals. They sleep so poorly that they're never going to get rest. You can tell them to sleep more all day long, and it's not going to help them. They're too tired to exercise, and they're too tired to eat well. And they're too tired to meditate or do anything proactive to manage their stress. So even if stress is the only reason they got this way, sometimes giving them thyroid hormone for a while will pull them out of it and allow them to then manage the other parts that are contributing and go back to normal. So what do we do? So start with splitting their levothyroxine or whatever they're on, even if it's Armour Thyroid, to level out the highs and the lows for a couple of weeks. And for some people, they actually start feeling better right away with this alone. The next thing is you want to carefully question them about adrenal function and start working on getting this better if they show signs of adrenal insufficiency, like salt craving, fainting, or orthostatic dizziness. That's a topic for another day. Then do all 5 of those tests, plus the calculation of the ratio every time you test. And generally then 6 weeks after every medication change again. So you want to pick a time of day to do your testing and keep with it. I personally like that mid dose, not the peak or the trough. This may be a little inconvenient, but lunchtime is okay with most patients once they understand the need for consistent lab timing. If you do the labs in your office, you might actually have to have them come back at the noon hour or go to an outside lab just to get this right. And one thing I do need to mention is that biotin is a supplement that a lot of these patients are taking because hair loss is such a common symptom in these people. It's present in a lot of hair regrowth supplements, and it interferes with immunoassays. It makes them look falsely high. And so they need to be off that for about 4 to 5 days before they go on to do their testing. Remember, these reference ranges are broad. The ideal ranges are narrow. Free T4 is the storage form of thyroid. We already talked about what can happen if you have too much. So once again, I'll just reiterate, the ideal tends to be down at the very bottom end of the normal range, or even off the bottom of the normal range for a few people. I find people coming in on levothyroxine are consistently too high when treated with levothyroxine alone, but too low is not good either. And one of the questions that I got was that to remind ourselves that T3 does not cross the placenta. And so if you have a patient who desires to be pregnant or who gets pregnant, having a T4 that's in the low end of this range is not an ideal thing. And they actually really need to be up around this 1.3 while they're pregnant. And you may have to push the dose up because of the thyroid binding globulin going so high. So this low end of this reference range used to be 0.62. It recently, I think, actually moved up even to about 0.8 at LabCorp. And I mentioned before, it has direct effects and people really feel quite bad at very low T4. And it was changed upwards in 2009 due to, I don't even know what, political pressure maybe. The free T3 needs to be pretty tight. I don't like to see anything below 3.0. Total T3, mainly using that to compare to the reverse T3, apples to apples, because reverse T3 is a total number bound to thyroid binding globulin plus free. So reverse T3 in normal controls is present in a 10-to-1 ratio with total T3. I like to see between 10 and 14. The ratio tends to be very consistent across a range of total T3 and thyroid binding globulin levels and correlates quite well with whether the patient feels well or not. The absolute level of reverse T3 needs to be 8 or slightly higher. If you get the reverse T3 too low, once again, they're not going to feel too well. Their hair might fall out. So that's not a great thing. And finally, once again, TSH in someone who's not taking thyroid medicine and is asymptomatic, I think it's fine for it to be up to 2. Once they're on treatment, they can be low normal or even frankly low. I don't mind as long as their free hormone levels are in the normal range. And there are some reasons to drop the TSH low. For example, if a patient has active thyroid nodules that I'm trying to get to regress, treating with combination therapy like this is helpful to push their TSH quite far down. You don't want to get the free T3 and the free T4 high out of normal range, but letting the TSH be low is fine. One other situation where I have done this is if a patient has Graves' antibodies, or if they are hyperthyroid and they are taking methimazole, to force down the T4 and the TSH numbers, then I will do that. And then I will replace the T3 and some T4 to give them less of a roller coaster ride. Because what will happen in these patients is if you try to balance the methimazole to get things right, one, their T3 is really still going to be quite low because of the fact that it's been fluctuating. And two, they're going to have times when the methimazole they're on isn't enough, and then it's too much, and then it isn't enough, and then it is too much, because the activity of the antibodies is fluctuating. So the second thing you want to do is, if you get numbers that you don't like, replace 25 micrograms of the T4 that they're taking with 5 micrograms of T3, divide it up like we did in the case. Recall that the patients are going to need to cut the pills. And I will tell you, there are quality issues with some liothyronine generic. The low quality ones are impossible to cut without shattering. The brand of generic liothyronine that I like the best is Sigma. There's another one that I tried recently that's called North Star that seems to be pretty good, and it's okay to cut. But these low quality ones, they just shatter and you can't get an even dose. So you probably want to stop and retest, especially if you're new to doing this, at or even below 15 micrograms of liothyronine. You want to stop before the level you think is going to be ideal for the patient. And if they become symptomatic while escalating, you want to go back to the previous week's dose. And you never want to change more than one thing at a time, even their other supplements that might be interacting, or their blood pressure pills, or their cholesterol medicine, or whatever. So why is this so important to divide these doses? Well, don't people need more thyroid hormone in the morning? Maybe a little, yes. But most of the increased energy that healthy people have in the morning is actually due to the circadian nature of their cortisol secretion. And that fluctuation really does matter. So the ideal physiologic way, and I mentioned this the other day, the ideal physiologic way for people to get thyroid medicine, or T3 in particular, would be in a pump, like an insulin pump. Twice a day is, or even 3 times a day is better than once daily. And this is definitely the case with the 6-hour half-life of the T3, but it's also better for T4 for the reasons that I discussed before. So once the patient's reverse T3 is high and the T3s may be down, it can take weeks to get the reverse T3 signaling to calm down and let it start dropping. And you may actually have to go back and work on their diet, work on their insulin resistance, work on their stress levels, work on their sleep, habits especially, to get things better. Here's another thing. Perimenopause and thyroid issues overlap phenomenally. I mean, if you look at the list of the symptoms side by side, they're like 80% concordance. And so the menopausal hormone levels really, really matter. And so if you've got somebody who's over 40 and you're trying to get this taken care of, and they're saying, you know what, I still can't sleep, I'm still hot and cold, I'm still this, I'm still that, maybe it's time to move on and look at their menopausal hormone levels as well. But what I do with these these thyroid levels is that I gradually switch people over 5 mics of Lyo for every 25 mics of levothyroxine every 2 to 4 weeks until I've got them where I want them. And once they're on the treatment, it's important for the patient to be consistent about what time of day they take their lab draws and what time of day they take their medicine on the day they get their lab draw. Anyway, so the alternatives to regular generic levothyroxine is, first of all, use the better forms of levothyroxine, use the Synthroid, use the Terracent, use the Levoxyl. They're actually much better than a lot of the generics. Take it twice a day instead of once. You can also use natural desiccated thyroid. In that case, I still feel like things need to be taken twice a day. 60 micrograms of natural desiccated thyroid or Armour thyroid contains 38 micrograms of T4 and 9 micrograms of T3. When I write it in the chart, that's how I write it. They're taking 38 plus 38 and 9 plus 9 or whatever. That's how I write it. The synthetic T3 and synthetic T4, the disadvantage is this very short half-life. Once again, I do not find the compounded sustained release formulations to be helpful at all. The patient just needs to know, look, you're going to have to get used to taking this twice or 3 times a day. I've been doing it for 20 years. It ain't that hard. Set an alarm. One of the things you can do if a patient feels kind of good on natural desiccated thyroid, but their TSH is too suppressed and their T4 is too high and the reverse T3 is too high, is that you can lower this slightly. And if they really like it, you can say, okay, I'm going to lower it a little, but I'm going to give you a little bit of T3. So in that case, sometimes people will be on 30 plus 30 of natural desiccated and 5 plus 5 of liothyronine. That's a reasonable way to do this. Remind patients this is not the standard treatment. Review the symptoms of excessive thyroid with them or T3 spikes with them. Keeping in mind that the symptoms of too much thyroid and not enough thyroid are often the same. The dose response curve tends to be bad, and then there's an ideal, and then so it's an inverted U-shaped curve. First you build the dose, and at first nothing seems to happen, and then you feel better, and then if you take too much, you're going to feel worse. But here's the thing. So generally patients on too much thyroid become either too tired or too wired. And unfortunately, the symptoms of too much and too little are really, really similar. And there will be a sweet spot. I'm going to just say this again. The ideal dosing regimen for liothyronine that I have come up with is 3 times a day. Side effects of too much include upregulation of T3 receptors. And there are confounding factors because people, when they start on T3 and they've had low T3 for a really long time, have probably been on a lot of caffeine. And they can have side effects related to that elevated caffeine. Like they'll say, Doc, I'm waking up at 2 in the morning and I can't fall back asleep. And that's because caffeine actually has a really long half-life. And once you've been asleep for a little while, your adenosine drops and your caffeine is going to stimulate you to be awake at 3 a.m. Another thing is you can get transient bouts of low blood sugar because if they have a poor diet with a lot of starchy carbs, a lot of sugar, they will have high insulin levels, and these will fluctuate, particularly in the nighttime, and cause nighttime hypoglycemia episodes. And I've actually started fairly recently putting my patients on a continuous glucose monitor while I'm trying to get them to improve their diet. And it really does seem to help. Another thing is, as you raise their T3, their sex hormone binding globulin is going to rise. And if they have been taking estradiol or if they are in perimenopause, their free estradiol levels are going to drop as that sex hormone binding globulin binds up more of it. And that will also result in insomnia and hot flashes. So you're never wrong to test in this situation. So the maximum initial dose of T3 should never be more than 0.28 micrograms per kilogram per day. But all of these things the T3 tends to get the blame when you've just started them on it. So it's important to measure and go, oh, look, it's below 4. It's fine. Here's these other things we need to look at. That ratio really helps eliminate the guesswork, particularly when you add it to a free T. So then I'm relying much less on the TSH as an indicator of thyroid function. Because it allows me to ignore the variations in the levels of the binding proteins with the menstrual cycle, with pregnancy, with oral contraceptives, with illness, by comparing those total values of T3, reverse T3. And keeping in mind that T4 is always going to be deiodinated into T3 or reverse T3 before it is cleared from your body. And so that ratio is really better than TSH. There are a lot of weird syndromes where this problem shows up. And I'll just list them really quickly so that you'll be thinking about it, because chronic fatigue syndrome, demyelinating disease, and that was in animal studies, depression, dementia-related behavior problems, heart failure, low metabolic rate, toxin-induced euthyroid 6 syndrome or toxic shock. And keep in mind, these tests, if you are an integrative or a direct primary care doc and your patients are paying cash for their labs, this whole lab set of 5 costs my patients about $45, and that's my cash price, including a little bit of a markup that I can get for them at LabCorp. So in summary, reverse T3 is an inactive but inhibitory hormone because it binds and blocks T3 receptors. Thyroid hormone doses must be divided every 12 hours for optimal results. Therapeutic blood levels should be tested according to peak and trough fluctuations, preferably, in my preference, at mid-dose. The ratio of T3 to RT3 is really the most accurate measure of the actual thyroid hormone function in the body. And some people need to take T3 even without T4 for their best clinical results. Now, it is possible to achieve truly remarkable results by applying the suggestions I've offered. And that is not the end of the story, because thyroid hormone is not working in isolation, because people's hormones levels fluctuate if they have autoimmune disease, because up to 20% of perimenopausal and menopausal women also have some variety of thyroid deficiency, because thyroid signaling, like estrogen loss, affects an enormous range of very similar clinical disorders, signs, and symptoms, like bone loss, high cholesterol, insulin resistance, chronic pain, mood disorders, and more. Because several of the causes of elevated reverse T3 are lifestyle choices or comorbidities that our bodies interpret and respond to with stress hormones. Anyway, that's what I've got for you today. I'm just going to put in a plug for the complete clinicians course that's going to start on June 9th. This is a free course. The live sessions are free. The first module, we're going to go into the way laboratory tests can fool you, and also an introduction to the philosophy of the new endocrinology. And then we will spend 3 weeks on thyroid, going into much more depth than I just went into for you guys. Then we're going to talk about the HPA axis. We're going to talk about the adrenal gland. We're going to talk about hormone replacement therapy for men. Then we're going to go into hormone replacement therapy for women and the Women's Health Initiative and all of the latest developments in menopausal care. Module 8, insulin resistance, metabolic syndrome, and type 2 diabetes. And then module 9 is bones and hormones, osteoporosis, parathyroid, vitamin D, and related problems. And then we'll do some case studies again at the end. So 10 to 11 weeks to get through all of this on Sundays, 6 Central. Because you are here, that means you are probably getting my emails and you will get the invitation to sign up for this course. As I mentioned, the live sessions are free. I would love to have you guys with me for that. And we actually have a weekly discussion group after the course is over. We invite everybody who has completed the course to attend the discussion group, bring their cases, bring their questions, and we just talk about all this stuff. And we talk about difficult cases. We talk about relatively straightforward cases. No question is too dumb. No question is too esoteric. And we just talk, and it's really super helpful. And I have now based my entire practice on what I started learning in this course. So, any questions? Any more questions? Okay, I'm going to answer what's in the chat already. Timing the blood draws. Really, after I've changed the dose in a patient, I wait an absolute minimum of 2 weeks. If they feel great, I'll change it. I'll wait till about 6 weeks. If I think I'm going to be making more changes, I'll go quicker. They do not have to be NPO for their second dose of T3, although it's nice if there's been 30 minutes, especially if they ate soy for lunch. Next question is, T3 doesn't cross the placenta. How do you manage the patients that are seeking pregnancy or who are pregnant? So I spoke on that just a little bit, but I really test them very often, and I make sure that their T4 stays around 1.0 to 1.2, and that their T3 level stays in the middle of the normal range. 3.3 to 3.5 is best. Gynecologists get kind of freaked out when the TSH is 0. They also don't like it when it's high. So most of the time I really try hard to work with them. A couple of other things. So problems with escalation and follow-up. People can skip their follow-up. Patients can skip their follow-up, and that is never a good thing. Patients can also run beyond their directions and take more thyroid than you intended for them to take, particularly the T3. If their dose gets a bit high, it can feel pretty good for a while because some people kind of like being a little wired, but it's risky. Some forget the dose response curve. When an overdose made them tired again, they thought they needed an even bigger dose. So sometimes that can be a concern. And like I said, if they get to a dose where they feel worse than they did at the lower dose, it's always better to stop, go back and test. Make your patients make timely follow-up appointments and hold the patient to keep them. I mean, it's cruel to stop their meds, but if they don't come for follow-up testing, then prescribe enough tablets to allow for some goofs and reschedule them, but limit their refills. They can't just keep going and going and going without testing because it's dangerous. So some failure causes. So first of all, one failure cause is that Cytomel, or not Cytomel, not the brand Cytomel, but some of the cheaper levothyroxine can be contaminated with reverse T3. T4, same thing. Some cheap generics are contaminated with reverse T3. So if your patient is better but not well, so for example, like say their free T4 is 0.55, but their T3 RT3 is still less than 10. So how do you prove it? Well, first of all, you might want to switch from the generic to the branded Cytomel and then retest. So if their RT3 then lowers and their T3 RT3 is now 12, then you've proven that particular generic was contaminated. And at that point, then you might actually, if their free T4 is still less than 6 or less than 7, I actually don't like to see it less than 7, then you may need to add more T4. And yes, brand Synthroid, brand Cytomel are better. They just are. And I am going to leave this up for a second. Does anybody else have any questions? Anybody else? Oh, Barb, I saw you come in. My goodness. I guess we'll get you the replay tomorrow and you can watch because we are nearly done here. All right, I'm going to go ahead and stop share. And thank you guys for coming. Does anybody else have any questions? All right, if that's it, then I'm going to stop recording. And I enjoyed speaking to you guys, and hopefully we'll get to talk again sometime.